This second module will introduce ocular pathophysiology and the effects of diabetes on the eye and retina. In the United States, for people with diabetes over the age of 40, the prevalence of retinopathy is 28.4%. Of this number, 4.4% are estimated to have sight-threatening retinopathy. The eyes offer a unique perspective to understanding about the underlying mechanisms of diabetes complications throughout the system. The progression of vascular compromise and complications can be directly observed. Generally speaking, the vascular changes we see in the eye are similar to those occurring in other parts of the body. The three major risk factors for diabetes-related retinopathy are hyperglycemia, hypertension, and time since diabetes was first present. Retinopathy manifests in the retinal vessels that are located in the neurovascular layer of the retina. Looking with higher magnification at the capillary level, the essential components are indicated in this slide. They are, from left to right, the basement membrane, the astrocyte, the pericyte, the endothelial cell, and the neuron. Collectively, these components make up the neurovascular unit. First described in 1873, the current name of pericyte was coined in 1923. Their function is to provide support, stabilize the microvascular structure, and regulate signaling pathways with endothelial cells, astrocytes, and neurons of the neurovascular unit. According to Winkler and Bell, pericytes serve as vital integrators, coordinators, and effectors of many neurovascular functions. These include angiogenesis, blood-brain barrier formation and maintenance, vascular structure and stability, regulation of capillary blood flow and clearance of toxic cellular byproducts for proper central nervous system's homeostasis and neuronal function. This illustration shows the different pericyte interactions with elements of the neurovascular unit. This is a summary of the more important pericyte functions as a constituent of the blood-retina barrier. They are vessel stabilization and new vessel formation, blood flow regulation and neovascular coupling, and participation in tissue repair and regeneration. This slide shows how hyperglycemia and hypertension negatively influence the function of the pericyte. Hypertension causes pericyte damage by activating the renin-angiotensin-aldosterone system, along with other hemodynamic changes that cause pressure imbalances. Hyperglycemia produces advanced glycation end products and causes osmotic damage via the polyol pathway. If hyperglycemia and/or hypertension are not optimized to normal homeostatic function, a cascade of events may commence that will result in pericyte dysfunction from various factors. If these factors remained unmanaged, pericyte dysfunction will eventually lead to pericyte death. Diabetes retinopathy may begin at this early stage of pericyte dysfunction. Thickening of the basement membrane has also been identified as a factor contributing in diabetes retinopathy. It has also been proposed that chronic hyperglycemia may cause retinopathy by direct action on the endothelial cell. Vascular endothelial growth factor, or VEGF, as starred on the screen, is secreted in response to vascular ischemia or hypoxia. It acts by increasing vascular permeability and is involved in the formation of new capillaries or neovascularization. Connecting the dots, when the diabetes is poorly managed, the pericyte and neovascular unit become more dysfunctional and are unable to correctly regulate increased amounts of VEGF. This speeds up the progression of retinopathy. VEGF is only one of the many factors that exert an influence on retinopathy. Originally, this molecule in anti-VEGF therapy was studied for its effect on wet macular degeneration. Because of similar vascular implications, it has also been found to be a useful treatment option for diabetes-related macular edema. As mentioned earlier, the eyes are uniquely suited to visualize the stages of change of diabetes-related retinopathy. Early nonproliferative retinopathy is characterized by microaneurysms, intraretinal hemorrhages, venous dilation, and cotton wool spots. This may also be associated with retinal thickening and swelling. Hard exudates are composed of lipid deposits that are remnants of vascular hemorrhage. Macular edema occurs when swelling or hard exudates are located in the area of the macula or fovea. This retinal image shows a microaneurysm and a cotton wool spot. Cotton wool is a term coined for the faint white wispy appearance that results from retinal ischemia. The illustration on the right shows the general geographical location of the lesions. In this image, we see hard exudates and a retinal hemorrhage. Notice that the hard exudates are located outside the macular region that is designated with a star. This is the special case of hard exudates located in the macular region. This is macular edema. Because this area has the highest visual resolution and acuity, lesions located here can cause a dramatic decrease in vision. Macular edema can potentially occur at any stage of diabetes-related retinopathy. Severe nonproliferative retinopathy shows increased hemorrhages and hard exudates. With increasing amounts of ischemia and vascular leakage from the closure of retinal vessels, intraretinal microvascular abnormalities called ERMA and venous beading are sometimes noted. This image shows an enlarged section containing ERMA. The irregularly shaped vessels appear similar to neovascularization, but are usually contained within the layers of the retina as shown. Venous beading, named for the irregular caliber of the retinal veins, is also a sign of severe nonproliferative retinopathy. With the exception of macular edema, people with nonproliferative retinopathy are usually not aware of visual compromise or suffer any quality of life issues during this stage. With continued ischemia and hypoxia, closure of vessels, and vascular leakage, new vessels are formed in an attempt to reduce retinal ischemia. Proliferative retinopathy begins with neovascularization, and at this stage the effects of retinopathy are usually considered irreversible. This is a picture of neovascularization in the area around the optic disc. The small, irregularly shaped vessels almost take a fanned or frond-shaped appearance. These fragile vessels are located between the retina and the vitreous interface. Neovascular vessels are very fragile and susceptible to fracture. When these vessels break, they can cause large hemorrhages. This is a vitreous hemorrhage from a broken neovascular vessel located between the retina and the vitreous. As these hemorrhages start to resolve, fibrosis and contraction of the fibrotic tissue can manifest in a retinal tear or detachment, further reducing vision. This slide is an example of fibrosis due to diabetes retinopathy. The take-home point to remember is that the degree of retinopathy increases with increasing dysfunction of the pericyte, neovascular unit, and dysfunctional levels of VEGF. As you now know, vision loss and blindness does not directly result from diabetes-related retinopathy. Retinopathy is the catalyst which triggers secondary complications such as macular edema, vitreous hemorrhage, and retinal detachment. The following slides will illustrate less known ways that diabetes can affect vision. People with diabetes are 5 times more at risk to develop a cataract. A cataract is an opacity of the crystalline lens. Chronic hyperglycemia related to age formation, the polyol pathway, and PKC activation fuels cellular dysfunction and increases cataract formation. In addition, higher levels of glucose in the aqueous humor is absorbed into the lens, causing swelling and what is described as a snowflake cataract. These are two examples of a diabetes-related cataract. In early stages, cataracts are sometimes reversible when optimal blood glucose levels are achieved. Reversibility of cataracts diminishes with time and in the presence of hyperglycemia. Diabetes-related surface disease may also decrease vision and quality of life. 53% of people with diabetes report increased dry eye. Causes for surface disease include age formation and a variety of other factors. Over time, the cornea becomes desensitized from nerve loss. Corneal keratopathy is also another symptom which is marked by pain and decreased vision from surface defects. These images show the effects of keratopathy and corneal nerve loss from diabetes. Ongoing research is being conducted to determine if corneal nerve loss could provide a non-invasive method to measure peripheral neuropathy. It is also important to be aware that reduced corneal sensitivity to nerve loss can pose problems with contact lens wearers. Rubeosis iridis is the name given for neovascularization of the iris. It arises from the iris vessels and is thought to be triggered by retinal ischemia. The presence of rubeosis iridis is estimated to be as high as 50% of people who have proliferative retinopathy. This image shows the neovascularization that typically starts at the iris margin. Rubeosis iridis, if left untreated, can progress and cause vision loss referred to as neovascular glaucoma. Management of diabetes-related retinopathy. Current 2016 ADA Standard of Medical Care recommends optimization of glycemic, blood pressure, and lipid levels. The ADA also recommends an initial dilated eye examination and evaluation at time of diagnosis for type 2 and within 5 years for type 1. Additionally, it also recommends a yearly eye exam, the use of retinal photography as a screening tool, and before or during the first trimester for women considering or who are already expecting. The last 3 screening recommendations are open to modification based on person-centered care. If the level of retinopathy advances to the severe nonproliferative or proliferative stage, panretinal or focal laser photocoagulation and anti-VEGF intravitreal injections may be used for treatment. Panretinal laser is used to seal off neovascularization and reduce retinal ischemia and hypoxia. It is speculated that the laser burns destroy small areas of retinal tissue which reduce ischemia, hypoxia, and decreases signaling for VEGF. For macular edema, focal grid laser or anti-VEGF injections are used. Anti-VEGF drugs were originally developed for macular degeneration and for cancer therapy. It has since been discovered that bevacizumab, used to treat cancer, and ranibizumab, used to treat macular degeneration, can improve visual outcomes in 30 to 50% of patients with diabetes-related macular edema. Conclusion. To various degrees, Pericytes and the Neurovascular unit have been implicated as a key player in microvascular and macrovascular complications from diabetes and from other diseases, such as Alzheimer's, epilepsy, and the aura people experience with migraine headaches. Overwhelming problems are easier to overcome if broken down into smaller units. But diabetes management is not just about an area of specialty like the eyes. It's about connecting all the parts together to paint a quality of life picture. Persons with diabetes are the artists, and the picture they paint for themselves will be unique. Diabetes educators provide the paint, canvas, and easel, or empathy, communication, and education to lower barriers. I would encourage you all to consider eye screening as part of your practice, or at the very least, keep pace and be proactive about eye care. Thank you.